Next speaker will be Professor Peter Clemmensen, who will give a talk about the ECG in acute myocardial infarction. It's not a new topic, but perhaps he still can come up with some news.
Well, thank you very much, Chairman. I don't know about the news, but I really read the invitation for face value, and that is understanding the definition and looking at the ECG manifestation. I think there are some important things to reiterate from the manuscript that was published last year, or now 2 years ago, almost. And here are my disclosures. First of all, I want to say that this is the entire group. That was really a fantastic group of people assembled by Professor White, Thugerson, and Joe Albert. And we had to struggle with all these different ways of looking at myocardial infarction and the EKG group. You can see here that it's right there in the center. So classification in EKG is right at the center of everything, and I'm going to try to prove that to you in a couple of minutes. Well, first of all, despite of the very clear messages given by Professor Jaffer about how to interpret the troponins, myocardial infarction is not a troponin disease and is not defined solely by the troponins. And I think actually back home, my own fellows and residents often forget this. But this is actually what is written. Of course, it is a cornerstone in the diagnosis. You need to see this rise and fall. But you have to have at least one of the following to take into consideration the patient with their symptoms. And then there's also often a pretty young cardiologist or emergency physician who has to interpret the electrocardiogram properly. Because once you get down to the more, let's say, refined or later stages, although an acute wall motion study can be done with echo and others, these are usually done by more senior cardiologists or other specialists that come into. And certainly, when you look at autopsy, it's all too late when it comes to determining how to treat the patient. So, just to take some very basic things here, pathological Q waves with or without symptoms in the absence of a non-ischemic cause is really a very specific criteria for a prior myocardial infarction. And you have to look at that and still be aware of the Q waves. Now, I think we just discussed now for the troponins about the gender issue, and that has been solved from huge databases regarding the electrocardiogram. So mind you that we have different criteria for ST segment elevation that is greater or equal to 1 millivolt in all leads except V1 and 2 in men and women, with the criteria shown below that in V2 and 3 it has to be above or equal to 2 millimeters in men and greater than 0.25 millimeters in men that are below 40 years with that cut point. And in women, it's really much lower. And you have to be aware of that, not to apply the same thresholds to women. So age and gender specific when you look at the ST segment criteria. I'll give you some few examples later on. The non-ST segment elevation, important, no change for in comparison with the previous guideline, but you really have to look hard and not just say that the EKG is normal. These are quite small differences you're looking at. That is, half a millimeter of ST segment depression in 2 leads. And we chose that because it had been shown to really add prognostic value. And then T-wave inversions in 2 contiguous leads as shown on this slide. So for the Q wave, the criteria for prior myocardial infarction or established myocardial infarction is the Q waves greater than 0.02 seconds or QS complexes in V2 and 3, Q waves greater than 0.03 seconds and with a depth of more than 0.1 millivolt or QS complexes in lead 1, 2, AVL, AVF, V4 to V6. And it has to be in contiguous lead groups as demonstrated down here. And then for posterior infarction, it's R waves greater or equal to 0.04 seconds in V1 and V2, and an RS ratio greater than 0.1. and concordant positive T waves. I think even though this has not changed much, I think a lot of residents or even fellows would be unable to quote these very simple and basic criteria for the EKG, which is sort of the first line diagnostic test when you come in. EKG is also crucial in the definition in special categories like for silent myocardial infarction. Here the cornerstone is really the pathological Q wave that you have to look at, and of course then other supporting evidence like imaging. Now, understanding EKG manifestations in AMI is important beyond what is already mentioned. And I think that one of the great flaws that we have is actually that we're fitted with a brain, and the brain functions that it really prefers, especially in acute settings, to just recognize on pattern recognition. So a lot of the electrocardiographic misinterpretation really comes from just pattern recognition and just learning by heart a few simple terms such as ST segment elevation. I'm going to give you a few examples. Now, this is from the manuscript of the Universal Definition. These are conditions that confound the electrocardiographic diagnosis of myocardial infarction. And there's a whole host of pathological conditions and medications that you have to be aware of when you diagnose patients with acute cardiac disease suspected of CAD or ACS, both false positive and false negative. Now, this is from a 10-year-old paper, but still, I think, very great overview showing you normal ST segment elevations and normal variants that we think that we have to teach our fellows, residents, and interns, and even know ourselves. That is, these differences where you see ST segment elevation in a healthy young man with sort of benign repolarization. Then there's the early repolarization phenomenon that is seen in some races where you have this very early repolarization, often a peak T. And we have to know that this distinction is the presence of this notch. This is what distinguishes this 35-year-old person coming in having chest discomfort from the truly anterior infarction. And then there's also the normal variant that you've seen here that has not sort of been genetically identified yet. But again, you see there's both ST segment elevation, although minor, and inverted T waves. Again, the clear distinction is the notch right after the S wave. Other pathological conditions that we have to know and that often gives a challenge is left ventricular hypertrophy with its ST changes, the left bundle branch block, of course, with often ST segment elevation in V1 and V2, pericarditis, hyperkalemia, with emerging in severe cases of the T wave and the ST segment, and then a clear-cut AMI. Right bundle branch block, we specifically in the document talk with some degree to, because although in V1, 2, and 3 there are some ST segment changes that can be present, usually to the trained physician it should be no challenge to diagnose AMI, the presence of severe ST segment elevation in this condition. And then, of course, there's the Brugada phenomenon that sometimes also, especially patients who experience sudden cardiac arrest and are resuscitated, then the first electrocardiogram, if it displays a pattern like this, I think this has happened at all institutions, that the patients are rushed to the cath lab suspecting acute LAD occlusion. So I think one of the things in understanding the electrocardiogram is actually to read the document. I'm not trying to insult anyone, but sometimes we make things extremely simple by just looking at the table, and that is often what is being referred to. And I think actually in our text that I don't expect you to read, but there's a lot of information hidden in there that could not be sort of dissected into clear tables. And I'm going to just give you a few of the things where we have very clear guidance as to what to do in clinical situations. So just repeating that we need better education. That is one of my foremost goals here. And you can also, to catch patients who do not have ST segment elevation or depression in the beginning, do continuous multi-lead ischemia monitoring. Automated diagnostic algorithms are helpful, and they are being refined, although a lot does not come into the public domain of what improvements are actually being occurred. So some of the available options that we have looked at is additional leads in patients that have unclear symptoms or where you suspect an ACS but don't have a diagnostic electrocardiogram. I know there are other methods like multiple leads or mapping and even vectorcardiography, which is not globally being used to a great extent, but more for research purposes. Now, for identifying patients with left circumflex occlusion, which of course is a challenge for the electrocardiogram, as many of you know, because as you see, exploring the infrabasal part of the myocardium, we only have 3 leads, 3 AVF and 2. So sometimes if you have this, what we used to call in the past the posterior involvement, we actually suggest that you take the additional leads V7 to V9. And it's important also to know that you have, because you're in the back, you're further away from the heart, that you have a lesser threshold of ST segment elevation when you explore these additional leads. Another way to look at posterior infarction that still is unknown to many people is that when it comes to the occluded left circumflex artery, often you might have some minor changes in the inferior lead, but these might actually sometimes be completely absent. Usually, you might see some action in lead 3, but what is important is to have this ST, we recognize this, an ST segment equivalent, where you have in this situation quite exaggerated ST segment depression, horizontal or downsloping, and a key feature when trying to identify patients with a circumflex occlusion is, of course, that the terminal T here trying to get positive, oftentimes it's more positive than seen in this particular picture. Additional leads also in suspected right coronary and right ventricular involvement infarction is to take V4 and V3R, as shown in this picture, and also consider conditions in patients with chest pain, understanding that there is a clear correlate between the degree of ST segment deviation and severity of disease and also prognosis. So the more ST segment elevation you have, or the more leads with ST segment elevation in STEMI, you have a worse prognosis. And we also touch upon this so-called left main equivalent, where you have the maximum ST segment depression in V5 and V6 and elevation in AVR. So this patient fortunately fared well, was treated conservatively, and the ischemia went away. But when you did the diagnostic angiogram 3 days later on the basis of beta blockers and fondaparinux, you really confirm what could be suspected early on, and many institutions actually now use the left main equivalent as a access to the cath lab on an emergent basis. So with these few examples and caveats, I would like to conclude that the standard electrocardiogram remain a cornerstone in the operational diagnosis and fast triage of patients for reperfusion therapy, that is the STEMI part. And pathological Q waves, with or without symptoms, in the absence of non-ischemic causes, are highly specific for a prior MI. And ST segment depression in unstable angina and non-STEMI is associated with poor prognosis and should be captured in all ACS patients by repeated electrocardiograms or continuous ischemia monitoring. And knowledge of normal variants and pathological conditions other than MI associated with STT changes is pivotal to avoid misdiagnosis and non-indicated treatments. And in this day and age, that would be often called by the invasive cardiologist false cath lab activation. But also knowledge of uncommon ECG manifestations of MI is imperative to avoid undertreatment of high-risk patients. Thank you for your attention.
Thank you, Peter, for a nice talk. Please, if you have questions.
Yes, Jadar Sandoval, Minneapolis. I have a question in regards to the application of NSTEMI and STEMI to the type 2 MI population. You know, there's recent papers, for example, in the American Journal of Medicine, that have looked at the comparison of type 1 and type 2 MI. And they have applied the terms of NSTEMI and STEMI to the type 2 MI cohort. And wondering about your thoughts on the implications of that to clinicians and researchers. My concern is that, you know, for years and decades, the terms of NSTEMI and STEMI have been used to guide management, such as revascularization, antiplatelet therapies, among others. And if we use these terms in type 2 MI, it might cause some confusion. So some guidance about should these terms be used in type 2 MI or should we not use them?
Well, having been part of this group, you sort of can figure out my answer. I think it should be used. I know David would come more into this, but I think the distinction, if I understood the initial part of your question correctly, was whether we should distinct between STEMI and non-STEMI for the type 2. Is that correct?
Yes, for example, some of the emergent research is categorizing, you say, for example, type 2 STEMI, type 1 STEMI, type 2N STEMI, type 1 and STEMI. And some of, for example, these papers in American Journal of Medicine are suggesting this sort of are presenting data in such way, which if that's what's endorsed, it's perfectly okay. But one of the concern is what, for example, you know, the healthcare providers, the confusion that might attract, for example, to paramedics and other ones that for years have been trained that a STEMI means cath lab, and not that what would a type 2 STEMI mean? And that's...
Yeah, well, I see the conundrum where you're going, but I think oftentimes in our gestalt, the type 2 would be a non-STEMI, if you wish.
Yep. It's very rare and STEMI, yep.
Yeah, and I think if you have a type 2 MI, you could envision, let's not, for the sake of time, look at all these different cases where you actually might have a type 2 situation, so pathologically a type 2 situation, but you do have concomitant elevation on electrocardiogram, if you wish, transmural ischemia. I think that might actually be a case where a diagnostic cath might be needed. Mm-hmm. Maybe not an intervention, or probably not an intervention, but at least to define early on what is the possible pathology. Does that make sense?
Yeah, so, okay, and just to clarify, so then it is fair to conclude that for at least research implications, it is fair that if for type 1 and type 2, we can't categorize on ECG basis, subdividing NSTEMI and STEMI. That's my impression from what I'm getting.
So Peter, it's transmural potassium flux. So somebody came hypotensive, type 2, down to 30 millimeters of mercury, they might get ST elevation. So I don't think it distinguishes between the two. Same microphone.
Yes, Ursul Juarez from Mexico City. The left bundle branch block has been traditionally used as a criteria for good MI. And the question is open for the table. Some reviews has been called that the right bundle branch block as a marker of worse outcome in acute MI. What do you think about it?
Well, I think if you look at the pathological background, it sort of makes sense that right coronary, that it has a very bad prognosis, because usually when you have a right bundle branch block, you have a quite extensive block and a high risk of progressing into to AV block. So I think this is the reason why this is being found in some of the studies. And also, I think that left bundle branch block is seen as we grow older, and is very common. I think in most centers that have a liberal access for patients with suspected new left bundle branch block, you will see that the coronary intervention, the chance of getting a PCI, if you wish, in a primary PCI setting of left bundle is between 30 and 40%. Whereas if you have ST segment elevation, that what Joe Albert used to call the wild type, clear-cut ST segment elevation, your chance of getting a primary PCI that is having a culprit that is clearly defined is in the area of 90. So I think that one thing we've learned with these criteria and moving into a primary PCI era for the past decade, is that left bundle branch block is still a huge challenge. And there has been proposed criteria like the Scarbosa criteria that was published in the New England Journal of Medicine, proposing a sensitive and specific way of looking at left bundle branch block for diagnosing STEMI, particularly anterior STEMI, but that has not been replicated in subsequent studies. So it remains a challenge.
Okay, please.
Dick Kovacs from Indianapolis. I'd like you to shift into not into the acute setting, but for adjudication of myocardial infarction in a clinical trial, or adjudication in a safety database, for example. And a technical question, would you allow adjudication of a 30 millisecond Q wave based on a paper ECG only, or on calibration of a digital ECG, or both?
A great question. For the sake of time, I could not show the different Minnesota and other coding systems that have been used. In my personal opinion is that it should be digital EKGs in this day and age that we use for clinical trials and adjudication. But that having been said, I think globally that will be a challenge to acquire. So I would also, as a practical scientist, be willing to accept paper readings of Q waves in instances and parts of the world where only paper copies are available. But that's a personal opinion.
So, Peter, I didn't see Takasubu's cardiomyopathy on your slides. Can you help us diagnose that? Are there some ECG criteria? Is it an infarct?
It was mentioned there, and as you know, there has been some studies that try to look at the curves of biomarkers to distinguish. But now coming to the ECG, I haven't found it. We have a Takasubu registry ongoing, and we're capturing the EKG data. So, but I don't have the final answer. My impression is that it's not easy. I could not tell you the criteria for Takasubu in EKG. Do you have the solution?
It wasn't an easy question. So.
You never ask easy questions, but sometimes there's a trick.
I think you did very well with the lack of information. Thank you very much,
Thank you.
Peter.